Good morning, everyone. My name is Naomi White. I am Senior Manager Regional Partnerships and Public Health at Western Victoria Primary Health Network. I'll be facilitating the primary care stream today, and I'd like to firstly welcome you. Our session today is Growing Better Together, Child and Family Centred Healthcare Everywhere. Thanks to our Armchair Medical for sponsoring this session today. Please take time to visit the sponsors' lounges throughout the day. We couldn't do this without them. Please take note of the health pathways for the session today. In this first session, we'll hear how practices in our region are using or trialling some innovative approaches to embed child and family-centred healthcare into our clinics. First, we'll hear from Port Fairy Medical Clinic, followed by the Centre for Community Child Health. There will be 5 minutes for question and answers at the end of the session, so please hold those for the three speakers today. There's a live Q&A box for those that are online. We'll take our first question from the room. I'd like to welcome Dr. Eleanor Donelan and Carolyn Billington up today. Dr. Eleanor Donelan, originally hailing from Melbourne, completed her medical training in Geelong and Warrnambool before moving to Port Fairy. When she had, as a registrar, and she loved the cradle to grave aspect of general practice. When she had children of her own, she found herself drawn to perinatal and lactation medicine. Since becoming a practice owner and registrar supervisor, Eleanor has relished the opportunity to foster a supportive and inclusive culture for patients and staff alike. This includes hosting registrars when they're on call and catching up for home-cooked meals, and a beach walk with her 2 Labradors. Carolyn is nearly 30-year career spanned nursing from birth to death and all that is between, culminating her position as practice manager, midwife, feeding consultant, nurse, and I'm sure many other jobs at Port Fairy Medical Clinic. Carolyn's wish is that every patient receives a positive and inclusive experience every time they enter one of Port Fairy Medical Clinic's campuses. She's particularly passionate about patients from babies and to young adults and how they are engaged within their appointments. Welcome, ladies.
No, I'm good. See if we can get the height difference right for the microphone. I can throw my voice, it's all right. So we'd like to just start by saying thank you to PHN for asking us to come and speak today. When we were originally asked, we were unsure as to why, because we don't think we do anything that different, but then it gave us some time to reflect. Thanks Jill and Jade for the CPD points, and we've decided that we do want to be a family clinic, not just in name but in action. And so often clinics say they're a family-based clinic, but we do want our toddlers to teenagers to be able to come into a clinic, feel safe, say to their parents, I want to go to the doctor, for everything. And as we've all seen in numerous things over this weekend, COVID has really hit especially our teenagers. And we want our teenagers to be able to say, I want to go and see Dr. Reynolds, Dr. Donelan, Dr. whoever, and I feel safe to do so. And we have worked on that over the last couple of years. So we're just going to do a little bit of some perspective. Port Fairy Medical Clinic, we have 3 separate clinics. So in this little outline of the PHN, we cover a fair bit of that. So we have ourselves in Port Fairy, 15 minutes towards Warrnambool we have our Carolyn clinic, which is a smaller clinic, and 40 minutes above towards Hamilton we actually have our Macarthur clinic. Our Macarthur clinic is a more older demographic, but our Carolyn and Port Fairy one is certainly a younger demographic. We also collect patients we've had our 5th registration from Mount Gambier. We cover Portland, up past Hamilton, Horsham, and come right down and to the other side of Warrnambool. So Warrnambool's having a lot of clinics that are not open at the moment for new patients. Carolyn is gaining those patients, which is great, but we're also aware that there is a big demand. So We are very lucky. We have 12 GPs, 5 nursing staff and a wonderful plethora of receptionists who cover our 3 sites. And in amongst all this toddler to teenager stuff, we also cover a 95-bed nursing home and a 12-bed acute, which is right next to our Port Fairy Medical Clinic. So a bit diverse and, as I said earlier, you know, cradle to grave. Now, these are some of the conscious decisions we've made over the last 4.5, 5 years. We've kind of sat down and said, what do we need? Where do we go? What is required? And this will cover what we've found in our toddler to teenage. So we want to run a clinic with a family-based theme for patients and staff.
So when I started my time at Port Fairy Medical Clinic, I came as a registrar 14 years ago. I was not yet in the stage of life to have my own family, but I was struck by the family atmosphere. This was clearly a clinic that looked after an entire community where patients of all ages felt really welcome, really safe, really included. And I think the culture really starts with the staff. So I know that one of my colleagues, when she first came back from maternity leave, you know, would come into work and have her little baby there, you know, even from very young, just weeks of age, you know, just do little bits of work here and there. And that was a generation before I then did the same. So when I had my own children, I felt absolutely supported to be very flexible about how much time I took off and when I was ready to come back. But I think, you know, every staff member knows that when we recruit them, we talk very openly about that family comes first. And we have that really explicit philosophy in terms of, you know, everyone in the clinic knows that we're not just workers, we're also family members. And I think that really then sets the tone for the overall clinic. Very much part of a community, and we'll talk to ways in which we have kind of reached out to our community in different aspects of what we do. But it really starts with that welcoming atmosphere for all.
And by looking after our staff, then also converts out. So we have husbands of staff members saying, oh, the clinic's so good, they do this, this and this. And they're saying it to other people who then become patients of your clinic and they want to bring their families there.
And I think that concept of recruiting for values and character has become a more kind of prevalent theme in recent years. When we recognised the need to branch out to Koroit, for example, that was a real demographic shift that we were recognising was happening in the region, with lots of young families moving to Koroit as an area that was affordable and nearby to Warrnambool, which had a lot of employment opportunities. And often they'd come pregnant with their first baby, and they didn't necessarily have a village. They didn't have supports locally, and we could see that they were all going through similar things, and we all know as new parents how much it can mean to be surrounded by peers and have that expertise building and peer group sort of stuff. So we wanted to try and create, and we'll talk about our shared care later, I think, a kind of an environment where they could feel they could drop in with whatever concerns they might have at any stage.
We tend to use some unconventional tools for appointments with children and parents. So if the parents, and this also includes our teenagers, so if the teenager is in the room and the doctor needs to speak to mum, they'll come out and they still feel safe in the waiting room with us. We'll have a laugh with them. Make sure you call them by name. So when they come in, it's not just the person paying for the appointment, it's the child that's important. So when they come in, it's, g'day, how you going? And call them by name and say hello to the parent, because they're important as well. But the child needs to feel that this is for me, it's not for, you know, this is not about mum dragging me here, this is about me and what's important to me.
And sometimes that means having flexibility around appointments, so some later in the day appointments, recognising that those kids aren't getting off the school bus until 4:30, you know, coming back to Port Fairy, for example. And so that then allows them to have that agency as young adults to come in and do medical appointments solo and build their independence and their self-advocacy.
Yeah. We also have inclusive spaces, and everybody tries to have inclusive spaces, but we have had some teenagers say to us, oh, you've got the flag there. And it's like, oh, you know, and a lot of us would look at it and go, yeah, but it's a sticker, you know. But they feel that they're included in that space. which
yes, and it's not easy to be different in the country.
No,
so I think
no.
especially for our trans or gender diverse young people, just some visibility of our, that this is a safe space is really important.
Yeah. We try really hard with continuity of care, and while we all try and do that, and even though we've got a lot of doctors, they're all still quite busy. So we do try and look at, okay, you're going on holidays, you've got a couple of kids that you're worried about, let's introduce them to somebody else before you go. And so we'll try and bring in another GP and say, this is who it is, they're going to look after you for the 2 weeks I'm away. We've just had registrars that have been away for 6 weeks, and we looked at that as well. Okay, have you got anyone you're worried about? Let's introduce them to someone else while you're away for 6 weeks, and then when you come back, we can get them in. Seems very simple, it's what we do every day, but in talking to others, it's not always what happens.
And I think Anne Holland's presentation before really just once again brought that into sharp relief for me, how often services are fragmented. And I think for me, I was sitting there going, this is really all about why generalism is so important and holistic general practice care, instead of siloing off and treating that part of that person or that part of that family, treating a whole family, treating a whole person.
And the last one, appropriate referral within the clinic. This has been something that the doctors have done themselves, really, that if they feel they're not getting along with the patient or that they're not right for the patient, they'll come out, we'll have a chat and work out who is. And we do the introduction again and we change it. Because, as one of our GPs said, they don't all want to see dinosaurs, they want to see some young ones. So it's just about getting that right fit. And sometimes they do want to see the dinosaurs because that might be what interests them. So looking at who is best for that person, not, oh, well, let's just slap you in with anybody.
And I suppose that dovetails into the recruitment. So we are fortunate in how our team has grown, but we've also been very proactive in our recruitment and try to get that diversity of age, life stage. Some of us are parents of young children, some of us are parents of adult children, some of us are not parents, some of it's, the adolescent girls want to go to the young glamorous GPs, and I don't blame them, that's fine.
But we've also very much catered in the last few years, so we've brought on board somebody who, while being in women's health, is also in obstetrics. We've got a couple that have looked at paediatrics and done a lot of work in paediatrics. We've had some that were teenage mental health, and it's been great because while you don't want for them to have all of those patients, they're there to help other GPs to guide them through and show them the way, and it's good. It's great in the lunchroom because you just hear the discussions. And I
think more broadly, like, we all love having a niche. It's lovely to be able to do the thing that you particularly, your eyes light up when I have a colleague who really loves geriatrics, and I say, please, can I hand you my complex elderly person? And they say, yes, can I hand you a screaming baby? And I go, yes, please. So it works really well.
It does. Okay. So our connection and engagement. So we've kind of split it because that's how we needed to. So our babies and toddlers, engagement with the new parents. Now, babies are quite complex on their own sometimes, but to engage with the parent, and by saying that, it's back to acknowledging we have a very clucky, it could be said, reception group. And so anytime a baby comes in, it takes nothing to say, oh, hello, who's your baby?
But one of my favourite things is to jump to exit the room and say, I need to examine mum, who wants this baby, and watch them run. It's so fun.
I usually win, not at the moment. But it is, and then you see the parents go, oh, they do care. They care about my baby, they care about me.
Yeah.
Awareness of language we use. This is a massive one in our world. We do a lot of breastfeeding and sleep, and that's massive. Making sure mum doesn't feel like a failure, so their baby is not, because that's what it becomes.
Yeah, the choice of language that you use is crucial. So people will hold on to a negative comment or I'm really worried about this baby. So so much of what we're doing is reassuring, validating, bringing them in touch with their own instincts.
And then with our teenagers, acknowledging that they do want to connect. We all know that COVID has really hit them, but what do? They're on Twitter, they're on Facebook, they want to be connected. And I spoke to my 17-year-old niece, I said, you want to be connected, don't you? She said, yes, and I do want to be connected to others, not always you guys, but we do. And so acknowledging that they want to be connected, so then saying, hello Emily, when they walk in the door, hello Eleanor. Encouraging their independence. So when they get to 16, we actually ask for their mobile phone number so that if there's results, we can ring them. Because sometimes they don't always want mum getting results. And talking to them about what's going to happen when they do become adults and, you know, what they need to look at going forward. And I can talk to that. Eleanor did a great job with my daughters when they had to move away and what they did. And acknowledging their concerns and fears. We still have a lot of teenagers who don't like the old flu jab, but not ignoring them and going, oh, get over yourself, you're of an age now. Talking them through, and half the time I'm standing there squeezing their arm and going, well, what's really worrying you? As I've given it, and they're telling me, and they're like, I'm not ready. Oh, sorry, it's done. But being able to do that and acknowledge that it's not that bad, but you do have a fear, it's okay. So it is just about, you know, letting them be them. So some of our different things, we picked up childbirth education during COVID because of everything being online. We were able to do it in a safe environment, face to face.
We make sure that the waiting room is a fun and inclusive space, that there's things for kids of all ages to do, and not just young children like to colour. It's often a lovely mindful activity for an adolescent.
It is. We've opened up community flu clinics on weekends so that it's not just poor mum or poor dad bringing in 4 children to do the flu vaccines, and we'll show you a bit more on that in a couple of minutes. Getting to know the patient, so diary planning has been huge. Getting to know the patient, and if they're coming in and it's going to be a long appointment, don't book them for 15 minutes. We just can't. So and our receptionists are phenomenal at this because they watch, they realise 2 appointments that have gone over 15 minutes, you're a 30-minute appointment next time. So,
got a 2-minute one.
GP and nursing diary collaboration. So when we do our immunisations for our children, it's a nurse and a doctor together, so that it's 2 jabs and then sometimes the 3rd, but it's not 3 individual ones. Simple things like that, and appropriate matching of the GP to the patient again. So we're on the last bits, I promise. So this was our COVID clinic. We had drive-throughs, impossible for children. So we changed it up. We had tents, we had bubbles, we had dogs. We always have dogs. So that was our COVID one. This was our community flu clinic on the weekend.
That's my son helping out. He was really proud.
So, and this is where we get in the family of the clinic, because then they're there for when their friends come in, their friends love it. These were our little special helpers that came through and helped us. Every year, I'm a bit different, but I run a craft club with our clinic kids, and we decorate the doors and decorate the clinic. It's amazing how many kids will come in and go, oh, look, this is so cool. They want to be there, and that's what it's about. Why do they want to be there? We did our introduction to childbirth ed classes, and then these were just some recommendations that we had for reading.
Some resources we often recommend. Yeah. But I think, it's just really about that family atmosphere, patients and staff alike, and it makes it a really enjoyable place to work.
And we recognise that not everybody has a big community health building that they can run a flu clinic, but even looking at an after-hours clinic where mum and dad can bring in the kids. Yes, it's a little bit of logistical nightmare, but it's not just an hour in our program that we just get them in and jab them all and get it done. It's about having a look at that big picture and saying what's better for the family and allowing those kids to have time and come in. And it is, you put on the music, you get the bubbles, you do that kind of stuff, and then the kids are like, oh yeah, I can go in there, that's cool. And that's what it's about.
Family medicine.
Yes.
Yeah.
Thank you very much for sharing your wonderful ideas and insights to your clinic with us. We are holding questions until the end. Please welcome Maria Fong. A Senior Project Officer at Murdoch's Children's Research Institute Centre for Community Child Health, Maria Fong draws on her extensive professional background in social research to specialise in program evaluation, co-design and quality improvement methodologies. Her work is focused on collaborating with stakeholders to co-design, improve and evaluate programs and services in the child and family service sector. Maria also synthesises and communicates research evidence through the development of resources and tools. With her expertise in these areas, Maria is dedicated to improving the well-being of children and families through evidence-based practice. Welcome, Maria.
Thank you. Okay. Let's just have a look. Isn't that nice? So thank you, everybody. I'm really excited to be here today, and it's really timely because I'm an evaluator at the Murdoch Children's Research Institute, and we've spent the last 2 years working really closely with the By5 paediatric project on their journey, evaluating it. And the final report just got on their website, I think, on Wednesday this week. So you can go to their website, read the final report. And, you know, this has been a really good, timely reminder to sort of start, how do we start sharing this information of what's happening? So just a bit of context. So the Wimmera Southern Mallee region makes up 20% of the state, but only 1% of the population. So it's that really diverse, you know, spread out. The region covers 6 local government areas, and the population, I think, is around 50,000, with 5% of those kids under 5, so about 2,500 kids under 5. So in terms of the issue that really, you know, speaks to Anne Holland's presentation, what we're seeing is, you know, there's this real need for services for children and young people. And there's a real gap in outcomes between rural and urban children. And this causes generational cycles of poor health, education and economic outcomes. And we know that it's linked to the large inequities in access to the right child and family services at the right time. And you'll see from this slide, you know, some of the barriers for rural and remote families are just services aren't available in their area. They have to travel quite a significant distance. That costs a lot of money. So it's a financial burden. It disrupts work, it disrupts schooling. There's a lot of other children to take care of. There's, you know, responsibilities on the farm, to the land. It's you know, a real bind to get to those services. So in terms of seeing what did this project want to change and, you know, start pushing in the right direction. So as in terms of improving that child health and development. So just taking a step back and looking at some of the data, there was a lot of community consultation done. So there's a lot of community conversations, and the data really backed that up as well. And, you know, what we're seeing from the AEDC data is that there's higher levels of developmental vulnerability. In Wimmera Southern Mallee, we're seeing from the school entrant health questionnaire a higher prevalence of speech and language concerns. So, you know, in terms of how things are tracking, we know that there needs to be more services and support available. In terms of supporting primary health care and helping them to, you know, offer, you know, available services, some of the data we looked at behind that was that the higher hospitalisations, you know, the high cost of travel to you know, Melbourne for paediatric health, you know, and 5% of children are visiting the RCH outpatients, and, you know, wouldn't it be good if there could be something in the local community that could take that up so it doesn't get to that situation? So this is the paediatric project, and it has 3 core supports. I'm really going to focus on the co-consultations today because that's what will be of most interest to the audience. But just briefly, the health literacy. So the project started in March 2021. So the health literacy really focused around, the sort of the bigger webinars, etc. In 2022, it sort of morphed into smaller offers using local professionals. So that might be the paediatrician and the local speech pathologist going to a local mothers group, a bilingual mothers group. In terms of capacity building, so that's around monthly case studies. They used to be unidisciplinary, so for maternal child health and for allied health and education, but last year they were a multidisciplinary offer. And so in those case studies, people will talk about some of the issues and challenges they've faced and work through them to think, how could we have done this differently or better? And then the co-consultations, which is where local professionals are the anchor, and they can access the paediatrician, so they support the family to access the paediatrician via telehealth and to talk through those developmental concerns. So this model really recognises that importance of local expertise and relationships, and it's trying to bring that paediatric expertise to those primary care settings where children and families have those relationships. They're already comfortable, they're already spending time. I just want to step back. This project is informed by, there's a UK Connecting Care for Children, there's also a Strengthening Care for Children running in Melbourne, and those two projects bring together paediatricians into the general practitioner's room and build capacity that way. The approach that Wimmera Southern Mallee and By5 have taken is to adapt this model for the rural and remote setting. So it's focusing more on not just GPs, because we realised how busy GPs are, but that allied health, social care, education. So this photo is of a co-consultation. So it's an example of what it would look like. So that's a local GP, the family, and the Royal Children's Hospital paediatrician dialing in. And so some things to note about the co-consultation is at the moment the wait list is 2 weeks, as opposed to a considerable long list for local paediatricians. And any health professional can refer. So you get maternal child health nurses referring, you get allied health referring into the program. And I want to be clear, this isn't a solution in isolation. This is really, it's working in partnership with local care. The kids and the families are always connected to that local care. The paediatrician provides interim support. 75% of kids last year had 1 consultation, with a quarter having 2 or more consultations. So it's really about providing that timely care, building up the capacity of the primary care workforce locally, with the view to moving those families, or not, the families were never taken away from that care, but just, it's a boost, I suppose. So I suppose I want to say I'm wearing my hat as an evaluator. So what we were really interested in is how this model is working and how it can be improved. Looking at the early impacts of the model, recognising it's a model that's changing and adapting. It's not, we haven't just said this is what we're doing and done it for 2 years. It's really iterating and adapting based on community feedback along the way. And what are we learning? And this is with the view to sort of take these learnings, because we know, maybe this will be of interest to other areas, or if this model specifically isn't of interest, maybe the principles behind it will be. So the main ways we collected data on the evaluation. We did 2 waves of data collection, so one in 2021, one in 2022. And there were a lot of surveys, but also interviews and focus groups to give you that sort of more in-depth thing into how parents and carers were finding these co-consultations, how were local professionals finding them. So over the past 2 years, 187 children participated in 314 co-consultations. So that's 187 kids that didn't have a solution right then, couldn't access anything locally, you know, that are on their way to a better outcome already, and that's what we're all about, is that early intervention. So we do know that it includes a number of families experiencing disadvantage. The data on that's a bit patchy at the moment. We're trying to improve our data collection systems, but we know that they've been supported by, you know, child and family services. We know they have a healthcare card. We know that, you know, there's a range of families that are benefiting from this, and families and professionals from all over the Wimmera Southern Mallee are participating. So I've put up there some of the most common presenting issues. There are a lot of presenting issues, so while these are the top 5, it was a whole spectrum, and what we found is that when children presented for the consultation, that other things came up as well. So, you know, it wasn't always what they went in for was even the most important or urgent issue they needed. And so those co-consultations, there were 367 professionals that participated in those. You'll see the breakdown. So maternal child health is one of the main ones, but also, you know, allied health, education, GPs, and that social care. So what are some of the benefits and outcomes we heard from families? And it really centred around timely paediatric care and that support of the local professional who could add detail in the consultations and follow up, you know. So, you know, they leave with an action plan, but often still families still need that support and someone coming back to them 2 months later saying, so how did that go, you know? Have you been trying those strategies? Have you, you know, been taking that medication? And we really heard that it just really relieves that burden of travel, cost and stress for families. It's, you know, some families still need to travel to Melbourne, but at least these co-consultations are a way to check in to see, you know, is that what needs to happen next? And so parents, you know, just like any consultation with a paediatrician, you know, they felt heard, it addressed their concerns. The parents felt that it increased their skills and confidence to manage their child's health condition. And as you'll see from the child health outcomes, you know, those are what you expect from going to a paediatrician. They're just happening earlier because we're getting that access for children earlier. So in terms of how professionals are benefiting, and again, it's around that increased confidence in assessing and managing child health conditions. Like hopefully some of these things, when local professionals have walked through them with families a few times, they'll have a few more tricks up their sleeves to try before they refer them to a paediatrician. And so we, you know, just that enhanced collaboration between professionals. We see some evidence that, you know, some professionals are saying, oh, you haven't been to the speech pathologist yet, I will come with you, you know. So they're seeing the benefit in this model of having that local anchor and can I help you reach out to your next support on your journey? So I just wanted to point out with the strengthening Medicare recommendations that have been released, it's interesting to note that this model, this local homegrown model, is kind of really aligns quite strongly with what's been proposed at a very high level. So about that increasing access to primary care, encouraging that multidisciplinary team-based care, modernising care, and that cultural change that goes on with it. And when thinking about what you can take away today, you know, what are the learnings behind the project? And so I suppose there's two things, and we are developing more research resources above and beyond the report. You know, what could this look like in your area? The Royal Children's Hospital are very excited about the model. One of their strategic aims is great care everywhere. So if we go to the nuts and bolts of what it involves a paediatric fellow 1 day a week, mainly via telehealth. They have paediatric supervision, but there's also a coordinator on the ground to run the program, and her background is nursing, so, you know, high level of skill behind that. And so, you know, you do need resources. You need funding, you need resources, you need coordination, you need governance. And we will be developing some resources for people that are interested in thinking about this. But what we also saw is a range of principles that sat behind how the model got up. And so it's that responding to the local needs of the community, really understanding what the needs are and tailoring your services accordingly. Thinking outside the box, and that may involve challenging those traditional norms and practices. But when you consider it, if you're child-centred and you consider it from the perspective of what does this child need, and stretch your mind around that, and allow yourself to start exploring some of those innovative solutions that prioritise their well-being. Like, we're not going to get this massive dump of funding anytime soon. So it's really, you've got to, you know, it's what you've got. How can you use it better? How can you use it more efficiently? And that gets to the next point of leveraging those local assets and tapping into that local expertise, the resources and support networks that already exist. And focusing on capacity building. So specialists should play a role in building the capabilities of primary care providers. Great, and then those prioritising relationships and integrated care. Okay, I think I will wrap up there. Thank you so much. It's a pleasure to...
Thank you, Maria. Don't go too far away. We've got a few minutes for questions. So I do want to just look at the room and see if there's a question in the room for us today. We'll just wait while our lovely mic runner does some running.
Thanks, Maria. Just wondering where to next for the By Five. Is it an ongoing program or is it sort of terminating?
No. And isn't that, you know, and particularly with the, you know, Victorian government at the moment is, you know, we're realising that, you know, money isn't going to be as available. But the By Five is funded for the next couple of years. And they're really looking at, you know, how can you embed it in the system so it's not a program, but it's just embedded and it's business as usual. But, you know, we will be continuing to, we work quite closely with them, continue to look at, you know, we're now at the stage of how do you keep it going? How do you keep that momentum going? How do you change things up so that the local workforce is still engaging and stimulated? We found that the project is really good for newcomers, so people that are just starting off on their journey, and likewise for those paediatric fellows. They've got this whole host of knowledge about community health that they just didn't have before. So it's ongoing. There's a lot of interest in this model. So, you know, watch this space, I suppose. Thanks.
Thank you. I'm just going to grab one question from online, and that'll come from Fiona.
Thanks. It's probably a bit more of a comment, but team-based care models are key to successful outcomes. Port Fairy Medical Clinic is a shining example of this model. Well done to you all.
Thank you. For those of you at home, you can't see it. The Port Fairy guys are very touched by the comment. I think that might be time, or do we have time for one more? We've got one more in the room.
So this question is to Maria. Yeah, it's just with regards to the By5 project is really interesting because I'm a registered community nurse and trained in public health. So looking at that, I'm just curious in terms of the social care aspect which was shown earlier. I'm just wondering if there would be space to look at some of the social models of care that we talk about in, the social determinants of health, and just wondering how that could be incorporated within the By5 model.
Yeah, that's really interesting. And the social determinants of health are so crucial to conceptions like this. What we're seeing, and it's interesting because the model is more from a health perspective, I suppose, and so it's social care's involved in the model in terms of really helping their families get that health care they need. And I suppose at the moment it's been more focused on people working in social care, learning about healthcare needs, but maybe that needs to go back a bit more the other way, so be that bi-directional. And I think it's starting. One thing I didn't touch on much was that in addition to the co-consultations, there's professional consultations where the paediatrician just talks to professionals about families, and that's been really useful for social care. There's a psychologist involved in those as well, so they're looking from psychology, medical, and so we should start reporting back on that because I think that's going to be really important. Thanks.
Thanks, Maria. Thank you to all those presenters this morning.